Hello, everyone. Thanks for joining. Today's session, we are continuing with urgent eye care, and I'm going to focus today on blunt injuries to the eye. We'll be talking about sort of penetrating and perforating injuries at a later date, but today we're going to focus on the blunt injuries. So, just taking a step back on globe injuries in general, some terminology that's worth sort of understanding is you've got sort of the separation between closed injuries and open injuries. So that, is in reference to the globe. So with closed globes, you can either have contusions, which is usually a result from blunt trauma, and then the damage can either happen right at the site or further into the globe. And then you also have lamellar lacerations, so things like lacerations to the cornea or sclera that aren't full thickness, where the globe is still intact, for whatever reason. And then looking at open injuries, so you've either got a full thickness laceration, again, usually by something sharp, or there's a full rupture. And the rupture can either be because something has been incised into the globe, a penetrating injury, or a perforating injury. The way I sort of remember the difference between what penetrating and perforating is, it's really silly. But essentially, if you try to add up the T's and make it three, that tells you how many walls are being have been damaged. So in penetrating, there are already two T's, so it's only one wall. So it's gone in one way, hasn't come out the other. In perforating, there's only the one T, so you need two more. So it goes through one wall and back out the other, and that's usually very kind of high speed missile injuries. Whereas with penetrating, it's usually something sharp. So we're going to focus today on blunt injuries, and we are going to talk a bit about globe trauma in the a globe rupture in the context of blunt injuries. But in terms of penetrating and perforating injuries, we are going to talk about that at a later date. So again, when it comes to investigating any trauma, you will want some form of imaging. X-rays can be handy in terms of just a very acute setting. You can sort of consider doing a very gentle ultrasound. So you don't, obviously, if you're worried that there is a trauma, you don't want to be pressing or applying any pressure to the eye because you can prolapse some of the intraocular contents. But a very, very gentle ultrasound can, if you're not sort of super sure from a first look, a very gentle ultrasound can give you an idea as to whether or not the globe is intact and whether or not you have the architecture that you're expecting. And then obviously a CT and an MRI can help. So in an acute setting, CTs are better, especially if you're worried about intraocular foreign bodies and anything metallic. You don't want to be doing an MRI. But MRIs can sometimes give you soft tissue. An idea of the soft tissue that's a bit better than the CTs, especially with context to something like the optic nerve. And then later down the line, you're obviously not going to do this in an acute setting, but electrodiagnostics can really help, especially if, for example, you have an otherwise normal eye and maybe you're thinking about whether or not there's any traumatic optic neuropathy, but nothing's really obvious. Then electrodiagnostics can sometimes help you with that. So moving on to the actual topic of today. So with blunt trauma, you're mainly looking at sort of sporting injuries. That tends to be the most typical sort of presentation, or there's some sort of, fight that the patient has been in, maybe a car crash and they've sort of hit their head against the dashboard. But it's blunt trauma is usually as a result of something where you've got an object that's larger than the orbital aperture. So something like a tennis ball, a fist, um, something that doesn't actually just go through into the orbit. And that's usually what then stops the globe from rupturing because it absorbs pressure, but really most of the pressure has gone into the orbit. And we talk about orbital fractures in a different session. You can go and watch that video as well if you'd like. But with blunt trauma to the eye, a lot of the time, the main areas that will be injured will probably be your lens iris diaphragm. That tends to be where most of the energy is absorbed. But really what determines your sort of visual prognosis a lot of the time is actually the status of the retina. So if you think about it, if you have a lens subluxation, for example, or a lens dislocation, you can take that lens out, replace it with an IOL, and actually from a visual point of view, they may end up with a very good outcome. But if they have a retinal detachment, or if they have a problem with a retinal hemorrhage, for example, sometimes the visual prognosis is much more limited because of that. So while the trauma is usually at the lens iris diaphragm, you want to try and know what the status of the retina is because that will determine the prognosis of the patient. So even a bit of a cataract or a lens subluxation and some AC hemorrhage may mean that the patient has come in with PL vision, but they may still end up with very, very good vision depending on what has happened to the retina. So when you're assessing trauma, it's really important again that you take a very much front to back approach, kind of be careful, looking at all of the different parts of the eye. And today's session, we're going to go through what you can see at the different levels and what may present in terms of in terms of what you might find at each sort of part of the eye. And early examinations can sometimes be really difficult because let's say, for example, they have an AC that's very, very inflamed, a bit of blood, maybe a cataract, and actually being able to see into the back can be really difficult. You may only have an ultrasound, but that's why serial examinations can be really helpful because if you start somebody who, for example, has a traumatic uveitis with a hyphaema, you give them lots of steroids and then they come in, every day, then that AC starts to clear and you start to get a much better view of the back. So these are patients that you're going to have an acute assessment, and that might not be the most complete, but that's why serial examinations are usually necessary in these patients because you can then, as the eye starts to settle, you can get a better understanding of what's happening and surgically, if there's any planning to do what surgery you may want to offer the patient. So starting with the front, we've spoken about lid trauma already. We've spoken about all features already. We are kind of focusing mainly on the globe. Near and I suppose the conjunctiva as well. You're going to look for any abrasions. Lacerations are usually not from blunt injury, but blunt injuries can cause abrasions. They can cause edema to the cornea, so you can be left with some clouding to the stroma. And you can also have some Deschamets tears. So you really want to take a careful look at that glaucoma, sorry, at that cornea. Um, to really just kind of see what the extent of the injury is, how this patient might need to settle, what the pressure of the what the pressure of the eye is, and we'll talk about a bit about intraocular pressure in a moment. So with the cornea, these are the sort of main things that you're going to come across with blunt injuries. Um, in terms of the AC, I wanted to take a moment to just talk about hyphemas. Sometimes hyphemas can occur spontaneously. They can occur post-operatively. So, for example, somebody with Fuchs who's got those sort of vessels at the angle, who with with into the angle has had after cataract surgery with a hyphema. But in the context of blunt injury, hyphemas can be quite often, can be quite common. And what you're trying to look out for is how large the hyphema is. So small hyphemas can sometimes settle down by themselves with a bit of steroids, but very large hyphemas might require washouts. Does the patient have, are they sickle cell? Are they sickle cell traits? Do they have thalassemia? You're wondering whether or not you can give these patients, what you can give these patients from an IOP point of view. So, are you going to try and avoid something like acetazolamide? Are you going to try and avoid something like dorzolamide topically because of these patients' medical history? Are they on any anticoagulation? Do you want to stop any of that? And then what you're also looking out for is signs of potentially a posterior rupture, and I'll talk about that in a moment in the context of a hyphema. And then just a comment on the fact that you can get something like red cell glaucoma, which I've spoken about in the past, and you can get this sort of blocked trabecular meshwork with the red blood cells, and essentially you just need to treat their pressure, and you may want to consider doing a washout as well. Fumes can also stain your endothelium, which means even once the blood has settled down, the patient's vision is still poor, and that endothelium, once it's stained, can be very difficult to clean. Um, so generally with hyphemas, in a traumatic setting, you want to just try and make sure that the pressure is managed and that it's not masking another injury, which we'll talk about later in this session. So when it comes to the management, it does depend on the extent. You're essentially suggesting bed rest to the patient, and you're mainly going to manage the hyphema with some topical steroids and some cycloplegia for pain. And you'll want to manage the pressure depending on what you can manage the pressure with, depending on the patient's medical background. And if it is a very large hyphema, something like an A-bore, then that will probably require a washout because it won't settle down by itself. And then you have the risk of um, uh, the endothelium if you leave that there too long. The other thing with hyphemia is that the risk of rebleed, especially in children, is at the 5-day mark. And in children who've had blunt injuries for whatever reason, either a toy or something at school, these kids are very mobile, they're very agile, and they can rebleed. So you really want to be making sure that you are kind of reviewing these patients again. And that first 5 days tends to be the riskiest time for these patients. So again, moving a step backwards, so looking at the iris and your ciliary body, one of the things that you'll come across most commonly with blunt injuries to the eye is a traumatic uveitis, and you essentially treat that as you would any other uveitis with a tapering course of steroids and some cycloplegia for pain. Um, but the other things that can happen is, for example, at the time of injury, you can get a sort of the iris essentially gets pushed back onto the lens, and you can get this pigment on the anterior capsule. As you can see here in this image at the bottom, you can see some pigment on the anterior capsule. You can get sphincter tears, which you can see in this sphincter tears, which you can see in this image above, where you can get some trauma to the actual sphincter of the pupil, and that can give you the traumatic mydriasis, which can be temporary, but sometimes these patients are left permanently dilated, and then you can get these small little bites out of the sphincter as a result of blunt trauma. And then iridodialysis, where you actually have a complete dislocation of the iris root, and that dialyzes and comes off. And that depends again, depending on how the extent of that injury will kind of determine what you do about it. You can either put some sutures in, or if there's an open globe, for example, and the iris actually just comes out, then that's tissue that you may have to end up losing. Um, so the most common things you're going to come across is probably a traumatic uveitis and maybe a traumatic mydriasis, but these more sort of high impact injuries can really end up with tears and iridodialysis. Looking at the angle and things that can change your pressure. So angle recession can happen with blunt injuries, and you can see that in this gonio image here. You can get, and the pressure can come up because of either a uveitis or bleeding in the eye. And just be really, really careful with eyes that come in with low pressure because they may be masking a posterior rupture that isn't obvious straight away. So you want to just try and be a bit cautious with patients that have come in with low pressure, as well as high. The lens, the main things you're going to come across are either a traumatic cataract, which can happen very quickly, or they can happen over several weeks following the injury. The lens can sublux, that's with either zonodialysis. The patient may have had a predisposing factor like a PXF, for example, or with just a good going blunt injury, even in a young patient, their lens can sublux. And the way that you can see that is either, as you can see in this image, the lens is quite obviously subluxed, but sometimes you can get some zonodialysis where the lens hasn't necessarily moved that much. And what you can actually see is just with the eye movements, the lens just looks very, very wobbly, which also gives you a clue that something has happened. But the other thing that you can see sometimes is actually you have some jelly in the AC. So you can see some vitreous in the anterior chamber. And the reason that that's concerning is, especially in younger patients that may have not had a PVD, the trauma may have caused one, yes, but if you've got vitreous in the AC, that's possibly pulling on the back. So that you might be sitting on somebody with a retinal tear or even potentially a retinal detachment with that vitreous coming forward. So do be very, very careful with these patients because if their retina is attached, then you afford a bit of time in terms of waiting for the eye to settle before you go in for a lensectomy. But if that retina is detached, then you might want to consider operating a bit sooner. The lens can completely dislocate, so it can literally just drop into the back or the front. Um, and also with blunt traumas, usually more common with penetrating injuries, but with blunt traumas, you can sometimes have a rupture of the capsule, and then you can get a sort of phacolytic or even phacoanaphylactic glaucoma. So that sort of kind of goes through what you can find on the lens. And really your what I've spoken about so far is probably the most common things you're going to come across with blunt injuries to the eye, where you'll have either a traumatic uveitis, damage to the iris, damage to the lens. And generally, if the retina is fine and the optic nerve is fine in these patients, once the eye settles down, once they have the lens removed and they have an IOL put in place, their actual vision can be very good. But it's the posterior segment stuff that sometimes um kind of leaves more permanent damage. So we'll sort of go through that. So in terms of vitreoretinal and choroid, you could just have a simple vitreous hemorrhage. That's just, sharing forces, some bleeding, and the eye fills with blood, and that's why they can't see anything. You might want to do you'll definitely want to do a B scan just to check because you won't be able to see through that vitreous hemorrhage. But if you're looking at a vitreous hemorrhage in the context of a low pressure, be very, very cautious that you might be looking at a posterior rupture. You can have some bruising of the retina, which is what commotio retinae is, and that's what this picture shows. And you can see this sort of grayish appearance to the temporal retina. And these patients usually they settle down over a few weeks, but that can sometimes leave a maculopathy if that commotio is at the macula. So these patients will require some follow-up. And then in terms of the other thing with the posterior segment is bear in mind that you can have retinal tears, retinal detachment, you can have retinal dialysis, for example. Those breaks can be happen anywhere, depending on where the impact is. They can happen at the equator, they can happen further forward, they can happen further back, and then the detachment can happen as a result as well. So do take a careful look at the back, especially if you have a view, and if you don't, that's why those serial assessments that I mentioned earlier are really important because then once you start to get a view of the back, you can have a better understanding as to what's going on, and whether or not there are any tears that need any lasering or if there's an attachment that needs to be reattached. And then finally, with choroidal ruptures, so just behind the retina, you can see these ruptures in the choroid where you're left with these sort of white lines where you can essentially just see the sclera behind the retina. Choroidal ruptures, if they're completely temporal, sorry, if they're completely peripheral, can sometimes not necessarily impact the vision that much. But I had a patient once who essentially had a 1.5 to 2 millimeter choroidal rupture, but he was so unlucky and it literally just went right through the fovea and his vision just drops to hand movements. So depending on the location of that choroidal rupture, you can be much more unlucky about what the visual prognosis is. But with choroidal ruptures, they tend to be a bit more peripheral, and if they are peripheral, then they don't necessarily have much in the way of a visual prognosis. In the acute setting, with a choroidal rupture, sometimes they can be associated with a hemorrhage, so you sometimes can't really see them that well. So once the hemorrhage settles down, you can actually tend to see this sort of white streak that you can see kind of appearing behind it. Um, Very, very rarely. Because you essentially have a rupture there, you can actually then have a CNV further down the line. So again, even if they're not center involving, they can then, neovascularize and then leak. So that's more just sort of chronic thing to think about when you're looking at your choroidal ruptures. And then looking at your nerve, the two main things, traumatic optic neuropathy is probably the more common thing that you're going to come across. So what you can see in that patient above, so looking at the two eyes, you can see in that right hand eye, that nerve is much more pale. That's not necessarily going to happen in the acute setting. It tends to happen more over days and weeks following the injury. But traumatic optic neuropathy can either happen because of a blunt injury or a direct injury to the nerve, an indirect injury with some bruising around it. And the visual prognosis almost depends on what they present with. So patients that present with NPL, for example, do very, very badly. And then patients presenting with PL, again, not a great sort of outcome for them. Um, Most of the time. And then what tends to happen is that you can either the nerve itself can either be compressed, it can kind of deform, there are sort of shearing forces that can happen. It all depends on the mechanism of the injury. The swelling can happen, you can even just have a shock wave that comes through. And these patients is usually, when it does happen, their vision is usually actually quite poor from the outset. So they usually present with quite poor vision, and that gradually gets better. But that pallor, like I said, is not usually visible immediately. It tends to happen over days to weeks afterwards. You're going to want some imaging. You're going to want some good neuroimaging to actually take a look at the entire optic nerve and see what actually has happened to it. And patients will kind of usually spontaneously resolve. About half of them will, and they do get some improvement. But like I said, if that initial presentation is NPL, then it's quite unlikely that they actually will will get a good prognosis by the end of it. Steroids, I mean, if you have an otherwise healthy patient, maybe, um, but you need to bear in mind that those with like an acute cerebral injury can sometimes uh, be put further at risk if you're giving them steroids. So you're not going to do that by yourself. And then, things like optic nerve decompression and stuff like that. I mean, this is, again, it's done really quite rarely um, for these patients. Then with optic nerve avulsion, I mean, this is really quite rare and it's quite a dramatic finding where you basically just have a gaping hole where the optic nerve is supposed to be, and that avulsion can either be complete or incomplete. And the prognosis is obviously going to depend on that. If it's complete, then, this patient is not going to be able to see. And there's unfortunately essentially no treatment for this. And basically what's happened is that the eye has been completely displaced. And then the optic nerve has just retracted from its sheath. So depending on the extent of the avulsion, will sort of determine the extent of the visual loss. But that's, that tends to be quite dramatic in terms of A, the presentation, and B, how what the prognosis is. So just a comment on rupture. I'm not going to focus on ruptures too much, and I'm not going to talk about fixing them today. We're going to talk about that in another session. But blunt injury can essentially cause a rupture anywhere. You'll come across in that the sclera is thinnest just behind the muscle insertion. So sometimes a blunt injury can happen there. But really, what you'll commonly come across is well, not commonly necessarily, but if you're getting a phone call from a patient who's had a blunt injury, and in their history they're also telling you this is a patient who's had a previous PK, or it's a patient with a trab, or it's a patient who's had cataract surgery, your alarm bells need to be ringing because these are patients that are constantly going to just be at risk of a globe rupture in the context of blunt injury. These are pictures of a patient that I saw. It was a patient who'd had a PK 20 years earlier, and then unfortunately got into an altercation with a punch to the eye. It was not that impactful. He had no other injuries at all. But obviously, because he had that PK, that is an area of weakness on the eye. And what you can see on the pictures, so here in the bottom left-hand side, you can see that the iris has essentially come out. There's basically an avulsion, that PK, sorry, that wound has dehisced and has come away, basically from about 1 o'clock all the way around to about 7 or 8. And you can see that on the fluorescein staining. And you can have the intraocular structures essentially prolapse through. And your blunt injuries, if you can see them anteriorly, they can either be completely corneal, they can be corneoscleral, or they can be scleral. And then we will talk about repairing globe ruptures at a later date. But this was just a comment on how blunt injuries can cause rupture. And then with posterior ruptures, this is where I was talking about the hyphaema and how it can be a bit of a red flag, where if you're seeing a patient with actually quite a deep anterior chamber compared to the other side, so the eye that's had the trauma has a deeper AC, or for example, you have an 8-ball hyphaema, or you have a really bad 360-degree subconjunctival hemorrhage, and you're seeing a patient with low pressure, these are all red flags leading you towards thinking about whether or not there actually is a posterior rupture in this eye that you may not be able to see anteriorly, but if you don't do imaging, if you don't do an ultrasound, you won't be able to see that this patient actually has a posterior rupture. So if you are getting these sort of features, a deep AC, a big hyphaema, 360 degrees of a hemorrhage, then just consider the fact that you might want to do a very, very, very light ultrasound or maybe a CT scan to try and see whether or not these patients have actually ruptured. So like I said, at a later date, we will talk about penetrating injuries and rupture repair as well. So just to summarize, when it comes to blunt trauma, take a very careful approach. Try and just make sure you're taking a front to back approach in these patients, and so that you're not missing any of the injuries. Because damage can sometimes really be masked, either because the anterior segment is essentially ruined and you won't be able to see anything into the back, which is why you can't see damage at the back to begin with. Or because actually a retinal tear can go completely unnoticed with no symptoms, or potentially because the patient also has a uveitis, they're not really complaining of any symptoms that would make you think that there is a tear. But then you want to go into the back and just make sure that you are kind of looking for any of those injuries. So that's us on blunt injuries. Thank you for joining. Please do remember to give us some feedback. And then we'll continue on later with looking at penetrating injuries and other types of ocular trauma in the acute setting as well. Thank you very much for joining, and we will see you at the next one.